All right, well then I will let you call us to order.
So I'll go ahead and call the third session of the Therapeutics Committee meeting to order for May 2nd, 2025.
And I will turn it back over to you for your re-review and extraction.
Great. So consistent with past actions of the Therapeutics Committee, we will operate with a consent calendar. We have recommendations from Optum. I would ask members of the committee to extract items from the consent calendar that they wish to discuss further.
This is Dr. Marshall. I'd like to extract the endocrinology GLP-1 section.
Okay. I'm going to go ahead and extract the agents for the treatment of opioid use disorder or overdose. And I'll probably also extract the miscellaneous oral anti-diabetic agents. Are there other classes that members of the committee would like to extract from the consent calendar? So items not extracted from the consent calendar will be voted on next. So I'm hearing no other extractions. So could I have a motion to proceed with the consent calendar?
So moved. This is Zach.
And I'll second it.
All right, thank you. So we have the consent calendar with the recommendations from Optum, with the exceptions of A1, agents for the treatment of opioid use disorder or overdose, C5, GLP-1 receptor agonists and combinations, and C9, miscellaneous oral anti-diabetic agents. If there is no further comments or discussions, we can proceed with the vote. Amanda?
All right, Dr. Shaw.
Aye.
Dr. Marshall.
Aye.
Mr. Musial.
Aye.
Dr. Negendank.
Aye.
Dr. Patel.
Aye.
And Dr. Weber.
Aye.
All right, we have all ayes, so that motion will carry. Thank you.
Okay, thank you. So we'll go ahead and proceed with the first extracted item in terms of order. So we'll go ahead with A1, agents for the treatment of opioid use disorder or overdose. Since I extracted the item, let me just sort of start things off with. I think, well, I mean, the T committee has heard over the last few meetings that there are a lot of issues surrounding the use of agents within this class, and in particular between Sublocade and Brixadi. I think there are aspects to this issue that are beyond the scope of the Therapeutics Committee, and what I would probably suggest is the first motion that I would probably invite from a committee member is first that we withdraw our request to Optum that we address this topic at each Therapeutics Committee meeting, so that this class will return back to its normal schedule for presentation, and the class will next come back to us in November of 2025.
I'll make that motion.
Okay. Yes. Could I invite a second?
I'll second that.
Okay, yeah. So we did ask Optum to present this class at each meeting. And I think I'm asking that we move it back to its normal review cycle. Any further discussions?
Dr. Shaw, could I amend that motion?
Yep, you're welcome
Dr.
to.
Patel, I guess my amendment would be to, I guess, ask OMPP to look at creative ways within this class that we might be able to manage some of the patient difficulties within the bounds of what the rules are within the SUPDL. So just, I don't want to say, go do this. I want to say, hey, let's go look, let's go explore, see what else we might be able to do in this space that might help accommodate some of the difficulties that we've heard about.
Yes, yes. You are like reading my mind, right? That was going to be my second invited motion.
Yeah,
so
let's keep the original motion just to change the timing back to the original, and then Dr. Shaw, you can make the additional
Yes.
motion after we pass this one.
Okay, thank you, Dr. Patel. Yes, so the motion at hand is to go ahead and return this class to its normal review cycle. And specifically what that means is that we would not review this class at the August meeting. If there's no further discussions, Amanda? I believe you're on mute, Amanda.
An oldest trick in the book. Dr. Shaw,
Aye.
Dr. Marshall,
Aye.
Mr. Musial,
Aye.
Dr. Negendank,
Aye.
Dr. Patel,
Aye.
and Dr. Weber.
Aye.
All right, all ayes, that motion will carry.
Thank you very much. So the second motion that I would invite, I think, concerns, I think, an aspect that Brian and I are both thinking in similar manner on, in terms of asking OMPP to consider how to perhaps address this issue in a little bit more of a comprehensive manner. Because I think what we heard from example with Dr. Metzger is that there are some process issues. And I think we heard from other physicians who testified today, like Dr. Johnson and Dr. Warner, that they would like some better access to this class. So I think there was a lot of technical issues that may be beyond the scope of the T committee and our review of just financial data. So I would probably invite a motion to invite OMPP to exert its administrative creativity.
So moved, Dr. Shaw.
And
I'll second that.
The office can, depending on the vote, the office can bring something back to the committee, whether we can or can't do and what we can and can't do, maybe at the next discussion around these agents. So,
yeah. Okay. So it sounds like we have a motion. This is probably the first time that there may have been a state of Indiana committee motion with the word creativity.
yeah, that's correct. To my knowledge.
Is there a second?
Yeah, I did second the motion.
Okay. Thank you, Dr. Patel. And any other further discussion? Okay, hearing none. Amanda?
Dr. Shaw,
Aye.
Dr. Marshall,
Aye.
Mr. Musial,
Aye.
Dr. Negendank,
Aye.
Dr. Patel,
Aye.
and Dr. Weber.
Aye.
We have all ayes, so that motion will carry. Thank you.
Thank you. The last motion that I would invite is a motion just to go ahead and proceed with the recommendations from Optum regarding this class, which is to make no change.
I'll make that motion. So moved.
And I'll second it.
Thank you, Dr. Patel. Okay, thank you, Brian. Any further discussion? Amanda? We need a roll call.
Yeah, sorry, I said Dr. Shaw, maybe it didn't capture it right away.
Sorry. Aye.
Thank you. Dr. Marshall,
Aye.
Mr. Musial,
Aye.
Dr. Negendank,
Aye.
Dr. Patel,
Aye.
and Dr. Weber.
Aye.
All right, we have all ayes, so that motion will carry. Thank you very much.
We'll go ahead and move on to the second item in order that was extracted from the consent calendar, which would be CE. Excuse me, C5. GLP-1 receptor agonist and combinations. Dr. Marshall.
Okay, I'd like to discuss the Zepbound prior authorization, how it came to the criteria, and explain on the reauthorization on the use of a sleep study, and is that going to be required every year that approvals are granted, or how was that decided upon to show measurements? And I guess the other question I had is sleep apnea is diagnosed with an AHI greater than 5. What was the reason that 15 was used, an AHI 15 in the initial authorization? Was that taken from the study guidelines? So
Yes, Dr. Marshall. So John, were you getting ready to talk? I don't want to.
No, I'm doing dual purposes here and I can't pull up stuff and do this presentation within this office. So
okay, so the guide,
No,
the initial authorization, those guidelines were taken from what the company used in their study?
Yes,
They-
so, oh, go ahead, Courtney.
Sorry, the indication is for moderate to severe sleep apnea, which
Oh,
is
moderate severe, okay.
defined, I think, as 15 in AHIs
Right.
and
That's correct, yeah.
Yeah.
Okay, all right.
The criteria, and why don't I just share this?
Well, that's fine. If that's what they use, that's fine then. I'm good with that. If that's per their guidelines, that's how the study was done, that's fine. On the reauthorization though, I'm a little confused on how they get this. It's every year that they have to be prior auth, or is it after 1 year they meet the guidelines their lifetime?
No, so it's every year it's going to require a review, and it is going to look at that they've had a reduction in their AHI from baseline. And not that, obviously some people will get to a certain point where they're not reducing.
wait,
Every-
sorry.
Oh, go ahead.
Sorry. Every part of the criteria for the reauthorization is going to be reviewed on the annual basis, but the AHI from baseline monitored or measured by a PSG would be like we deliberately did not put a time frame in there because we would just need one follow-up. So we would only need like the one from the initial reauthorization review, and then that could be used for the remainder of the reauthorizations, if that makes sense.
So they wouldn't have to do another one.
Correct.
Okay.
Not doing other sleep studies, right? And they should theoretically, like don't we have, oh, maybe I might be lying. I thought we had requirements around using an actual CPAP.
No, because that's my concern, is that some of these people are not going to use CPAP. And I think that's understandable that if they demonstrate a reduction in their AHI, that they don't have to keep using it as long as they meet the guidelines that the other guidelines that they're still using the drug regularly, instead of, here and there. But I guess I would set, I guess I would say that it would need to, I would have them repeat the AHI, because I don't think I'd want one in the first 3 months, because usually the way this drug is used is that you titrate it up in the monthly. And if I'm not mistaken, I think weren't there only 3 doses that were approved, that they got approval for, 7.5, 10, and 15? Or am I wrong there?
I am not. I would have to look that up.
I don't think all the doses, or well, maybe they all got approved, but maybe the rep is on the call that could say that, could verify that. But to get to these doses, 7.5, 2.5, 5, 7.5, at least 3 months, and to the higher doses, you're talking of the 6 months. So my recommendations would be that this repeat sleep study, if that's what you're going to require, should be within 60 days of a year. Within the 60 days of authorization of a year, so that they can keep pushing the drug, give a chance for the drug, versus we get a sleep study in 3 months, they haven't really lost any weight, and it hasn't made any difference, and then you got nothing, and then we're repeating sleep studies we're doing one, somebody did one at 3 months, and they're doing another one, and just keeping, so I would say within 60 days of a year, re-auth, that has to be done in the first, within 60 days. That's what I would say.
So we just to make sure we're both on the same page. So we would require an initial sleep study that would demonstrate the moderate to severe
Correct.
sleep
Correct.
apnea. Okay. And then we would give them a year approval at that point.
That's what it says. Approvals
Yeah.
would be granted up to 1 year, correct?
Right. And then we wouldn't require a follow-up sleep study until that year mark.
Correct.
Is that,
Correct.
you don't think that's enough?
I don't what now?
You don't think that's enough time to?
Oh, I think it's enough time. I'm saying you don't have a timeline here, and somebody might get one at 3 months after they started, and they haven't lost any weight, and then they repeat it again because it's no good. So I would just say that it should be within 60 days of their annual re-auth to see if it's gotten any better.
I was misunderstanding what you were trying to say. I'm sorry.
Yeah, and because
Here, I
you
think
got to
you're
get
getting a
to
little-
the higher doses, I'm pretty sure that they only got 3 doses approved for the sleep apnea. I could be wrong, but I
Here-
think it's only 3.
Dr.
Here, I
Marson,
think
it's just the 10 and the 15 milligram that's OSA approved.
Yeah, okay. I thought 7.5 did. Okay, so it's just 10 and 15. So I would say you might put those doses in, that they've got to be using those doses too. You don't want somebody just sitting on 2.5.
Okay.
Can I jump in here? So one, I'm looking at the dosing. I think they're all approved. The recommendation is that you use 10 or 15 for maintenance. But I think you can start with that 2.5 and work your way up. So I think they can all.
Oh,
be
you have
used.
to start at 2.5, correct?
Correct. So I think they'll all be approved for that indication. It's just the recommendation is use 10 or 15 for maintenance.
All right.
But I also think
So
you're getting a little prescriptive in the PA reauthorization here. Like, what if they're seeing great improvement at 6 months and they want to get the sleep study done? I think that's between them and their physician to figure out when the appropriate time is. We just want to see that over that course of the year that you've seen improvement. So whether it's 60 days before, 90 days before, I think you got to give the provider some leeway to figure out when that best time is.
You've got to ramp up the dose, though. That's the problem.
I'm aware. So that's why I think that's on the
And-
provider to figure out what's appropriate for that patient, when to redo the sleep study to make sure that within that year that you've seen improvement. I don't think we need to dictate that. We just
Well,
want
the
to see something
problem-
that shows improvement.
Okay, because okay, I think this is a new thing. We don't usually repeat sleep studies on people once they start treatment. And this is a new indication, and I don't want to see somebody getting one in 3 months and it isn't any better, and then they do it again in 6 months to see and keep running up sleep studies. I think,
Yeah.
if they kind of coming back, you should have it. You could get a year, because you can't. The other problem with these drugs is they recommend if you stop them for 2 weeks to start all over again, with it down at the 2.5. And we say, well, as long as you got 90 days in the last 120, I'm not sure that's good either. So I don't want to see people keep getting sleep studies, and I don't know what the problem is. You just say you get one at the year authorization, and that way you give them a year to get it done.
Met
So
somewhere in the middle and said, sorry, John, I was going to say, what if we met somewhere in the middle and say that it has to be at least 6 months after initiating therapy? So somebody's ramped up by then, and then it has to be within that last 6 months, depending on when they're seeing their person. So it's not super subscript. What's the word?
Okay. If you
I
want
don't
to
know.
do it after 6 months of therapy, that's 2.5, 5, 7.5, 10, 12, 15. Yeah, they'd be up to 15. Yeah. I could do 6 months.
So, Dr. Marshall, these
Ellie
CPAP
and,
machines are getting
well-styled girl
fancier all
here.
the
Yeah.
I
time.
think they're inside having lunch.
I was looking
Yeah.
for, I went that way. They said they're there. I'm like,
Yeah, yep. They, I was the first to check in, and then I saw them walking up, so they put the bags there, and I think.
Whoever's talking, please put yourself on mute.
So, Dr. Marshall, what I'm hearing is that we're sort of talking about requiring a second sleep study, but CPAP machines are getting, I guess, fancier now. What if these machines document a reduction in AHI? I mean, is that necessary that the people go through a second sleep study?
No, no. They're going to show, if you're going to put that in there, it's not in the reauthorization that's demonstrated. I'm just saying that's why I'm bringing this up. This is kind of confusing. The reauthorization says you got to show a demonstration reduction. So if you want to put that in there, that it demonstrates a reduction in AHI from baseline by use of CPAP, that's fine. But a lot of people quit using it.
Yeah.
The CPAPs after a while. You never know.
What about the Inspire device? Does that track the same thing?
You have to meet guidelines on getting Inspire. I'm not
But if
sure
they
that you'd
have
have
it,
to
right?
do it. You'd have to do a sleep study on Inspire on the device, I think. I don't think the device regulates that.
There's
It's kind of
also
like
track
when you do
apneic
a,
episodes?
I'm sorry?
Go ahead,
Wouldn't it
Zach.
track the number of apneic episodes though?
I don't know. I don't know enough about the Inspire device.
Yeah, and I think the Inspire device is not recommended in patients who have that high of a BMI.
No, it's less than 35.
Yeah.
You have to, the studies were done with BMIs less than 35. So that is over 30 though. Yeah.
So
Right. We would
can
have
I
a gap
make a
between 30 and
suggestion
35.
about the second open circle point regarding member demonstrates a reduction in AHI?
Mm-hmm.
So I think historically, as a committee and as OMPP, I'm not intending to speak on OMPP's part, but it's there's been the effort to try to minimize the amount of paperwork that has to get in front of the provider. I mean, what if we just ask that the member has active or recent management by sleep medicine center physician.
Well, let me tell you from a practicing physician, half my patients don't even go back to their sleep doctors.
Right. So if they don't go back to their sleep medicine, then they can't, then they're not reauthorized. I mean, are they even using the machine or using the machine appropriately?
The
Or having
problem
appropriate
is
monitoring?
where are they in the state? There are a lot of places that don't have sleep. I know Lafayette that it's managed by their primary care doctors, their sleep apnea. And you're going to have people in small towns that aren't going to be able to get to sleep doctors. So I don't think you can actually say a sleep physician in some of these small towns where they're not there and they're an hour or two away. And then
So just 1 second, Marshall.
So what if we just kind of give ourselves some flexibility and the clinical pharmacist and the call center's flexibility around saying something effective, provide documentation that clearly demonstrates that an improvement in some way. Yeah, thank you. Yep. Something along those lines.
okay, I'm good with that, but what are you going to define as improvement? Because that's what physicians are going to want to look for on the prior auth.
Well, what if you said something along the lines of member demonstrates reduction in AHI from baseline through either repeat sleep study or approved OSA device measurement?
What if it's just an objective reduction in AHI from baseline? Because then you'd have to have objective data to support that reduction, whether that would come from a sleep study or whether it comes from an OSA device.
Okay, what objective are you going to use? There are the
No, that
Epworth
would be
scores.
the objective, like objective data as opposed to subjective data. So objective would be verifiable data.
Right, but I don't think objective data is what you want to use for this in this indication. I think you've got to demonstrate subjective. Anybody's going to say I feel better.
So what I was saying the opposite, that the member demonstrates an objective reduction in AHI from baseline, and
Okay.
that would be objective data as in verifiable coming from a sleep study or from an OSA device. So they
Okay,
couldn't just come back and say, I feel better, because that would be
right.
subjective
I
data.
agree with that. I agree
Right.
with that. I could go with it that they're using a device. The question is, most guidelines say that you need to use the device 70% of the time, for 4 hours a night. So, are you going to consider that if they're using it once a month and it shows that they have less than AHI, then that's good, or what?
I mean, I think the idea is if it's showing less, right, demonstrating less than what their original was through either a sleep study or through that, I mean, you're still demonstrating that at some level, right?
Well, and I think that gets to what Dr. Patel mentioned about trying to find that balance between, letting the provider work with the patient, but at least the work that we would hope to promote would be that they would have some type of verifiable data of a reduction, and it would be up to the provider to determine if that verifiable data was good enough for them.
Yeah, I think we could like get into all the weeds in here. I think Dr. Weber's addition of saying through objective data, I think really gets us to the point of we want to see some improvement. And the other thing is this is brand new, so we could also revisit this in 6 months and get some data from Optum of how has this been going. We won't have any reauthorizations in 6 months, but at least get some idea of volumes and are we what we're doing with that.
Here's the thing. The drug itself does not do anything for sleep apnea. Okay? It's all based on the weight loss. All right? So if a member's not losing any weight, his sleep apnea is not getting better. Okay? There's no magical thing with this drug to help with sleep apnea. So that's my concern, not everybody loses weight with these drugs. Many people do, but each person is different. And if they're not losing any weight, their sleep apnea is not getting any better. So if you want to put a weight, they got to lose weight. That's a thought, but that's my biggest concern is that people, if they don't lose weight with this drug, it's not, you can't keep using it.
So do you want to replace the second open circle point with just a weight criteria?
Well, you can't just say they've lost so much weight and then their sleep apnea gets better. Each person's different. There's no guidelines for that. But
Well,
they've
what
got
about
to,
if
number
they-
one, demonstrate. I think you got to, number one, you got to demonstrate weight loss. And then number two, you got to prove that the sleep apnea has improved.
Well, why couldn't we create that second bullet to say both? Member demonstrates a reduction in weight of whatever, XY, at least XYZ, and demonstrates an objective reduction in AHI from baseline.
Well, I can see, if you got somebody, here's the thing, if you got somebody with an AHI of 16, okay, and they lose 5 pounds, that might drop them below 15. So I'm not sure you can say a certain percentage. I think you can say, they've got to demonstrate weight loss and show an improvement in their AHI.
So I just noticed in the chat that we do have a representative from Lilly here that offered to comment, and I think their perspective could be helpful. So Jennifer, if you wouldn't mind going ahead, please, if you're still here.
Yes, I am. Can you hear me?
Yes, thank you.
Yes, absolutely. My name is Jennifer Langford. I am the Senior Account Director for Indiana Medicaid for Lilly. And yes, I will comment a couple of things. One of the measures at some states is they are wrestling with this PA criteria, knowing that Zepbound for OSA is new, and a lot of the states are reviewing it. They are looking at this reauthorization criteria, and some of the comments that you all have shared have been consistent. So number one, wanting to ensure that the patient is taking the drug and that they are seeing an improvement would be, consistent with reauthorization from other states. One of the measures has been a reduction in weight loss. Meaningful weight loss is generally around 5% is what the literature says, just in terms of expecting what you can expect in our clinical trials with Zepbound around weight loss. And then, understood you'd want to see that the drug would be working, Zepbound would be working to reduce the patient's AHI as well as measured by however you all, meaningful data that I think the board was leaning towards. Are there any, and the group as well answered the question about the maintenance doses for the indication for Zepbound are 10 and 15 milligrams. If you look at the titration schedule of starting at 2.5 milligrams all the way to getting to that 15 milligram dose, it would take about 6 months to get that patient to that maintenance dose of 15 milligrams. So that would be the kind of the timeline, the earliest point that the patient could reach that maximum tolerated dose of 15 milligrams.
Right. Thank you.
Thank you, Jennifer.
Are there any other questions I could answer? Yes.
No. Appreciate it. So I would agree that we need to add that they have to have lost weight. If you want to start at 5%, I'm good with that, with what she said. And then I think you can demonstrate that their AHI, but I would not. I think it should be around the year. And that you get the study. You can do home studies. Most of these people qualify for home studies. You're not sending them to labs, but I don't want to see somebody get a study in 3 months and it hasn't shown any improvement. And it's a waste of time when it takes 6 months to get up to the maximum of 15 milligrams. So I would say.
I do have one additional comment that is not in the criteria. Most of the other states are already including home sleep test as an option, both for diagnosis and for reauthorization, because it is more expensive to get a full sleep test, and there are few sleep centers across, especially in rural America. So home sleep tests are verified as a viable device to diagnose and test AHI, and that may be another consideration, not just in the reauth, but the diagnosis part, that would allow kind of broader access to getting to that AHI documented number.
No, I agree with home sleep studies. They're fine, but there are contraindications to home sleep studies. So,
So we don't have a requirement one way or the other.
right,
It's,
right.
it's
No, I
just a
agree.
diagnosis. So however they
I
got
agree.
their sleep study.
Yeah.
No,
Oh, sorry, Courtney, am I missing something?
we require PSG, like we don't do the home sleep study.
For initial.
Oh,
You what now? You
We
don't
have
you
the
don't
PSG
include the
here.
home sleep study?
We do not accept the home sleep study.
Oh, you got to include that. You've got to accept that. That's standard.
So, since we have our friend Lily on, when they did their clinical trials, did they include data from home sleep studies for inclusion criteria?
So this, and I can pull up the slides. I know this is very unconventional, but in our trials, there were 2 trials with Zepbound. Some patients though were diagnosed using PSG in our trial. Just because it was a clinical trial, obviously all the PSG tests that are very expensive was paid for through the clinical trials. But in real world, what we believe is that most patients will have greater access to home sleep tests, which are more cost effective and
Correct.
also considered very reliable.
Correct. A lot of insurances don't even cover the sleep study in a lab unless the home sleep study is contraindicated. And that's where most diagnosis is in a home sleep study.
So this is Anne. Is a home sleep study able to rule out the central or mixed that is that the member could not have in order to get this?
Well, usually what happens is that it's read by a sleep doctor, and they if they see problems, they make a determination. If additional study is made, but there, like I say, there are contraindications to a home sleep study with asthma is one of them, COPD, Pickwickian syndrome, respiratory failure on oxygen. So yeah, they're not really. From my use, and they're reviewed by a sleep doctor. Then yeah, I think it would be okay to do that, but I don't think we should be requiring sleep or in lab sleep studies. It's costly, and there's a big back load to get in, back weight.
So, what I'm scrambling to do is to make sure that actually we cover the home sleep studies.
You would, John.
Okay.
John, everybody covers home sleep studies.
Okay.
It's a standard. It's a standard of care.
All right.
I looked at the speech is covered.
Okay. But I'm also going to say, and this is a valid point, is that, yeah, they're expensive, but so is the drug, especially over the long term. So
I understand, but John, that's the standard of care. People pick up the boxes and they do them at home. You can get them in faster, and it's better. You're running up a cost by doing that. Nobody does that anymore. It's the home sleep study is the order.
Tiara, I'm old school. Sorry, I'm just old.
I know.
I don't know about this.
I know. This is my concern with this
Yeah.
PA. That's why I'm bringing this up for discussion.
Yeah, I appreciate that. Yep.
So TR, if I were to summarize what you would like to make as a motion based on what I've heard.
Right. I'm actually typing something right now, Amanda, that I think summarizes what TR is trying to say.
Okay. If you want to do it, I think I've got his, I would say 3 things summarized as well. So up to you. Because I hear
just so that we have something concrete to start to discuss on.
Yeah.
Do you want me to summarize?
No, so I'll put it in the chat. Okay, of course, excuse the typos. So this will replace the second open circle.
Where are you typing this?
It's in the chat. So
This is
he's
a
saying
chat, meeting chat, at the
Uh,
top bar.
okay. All right. Let me find the chat here.
and I can read it to you. It says member
Top center,
demonstrate an
top center
objective.
TR, it's in the verbal menus.
Yes. A member demonstrates an objective reduction in AHI from baseline based on data from within the past 3 months through either PSG, home study, sleep study device, and meaningful weight loss from baseline defined as weight loss of at least 5%.
And this isn't for reauthorization?
This is
is
for
for the
reauthorization.
Okay. All right. I'm good with that.
Okay, I mean, do we want to define meaningful weight loss, as 5%?
Yes.
I mean, we can include meaningful weight loss, but do we want to say 5%, or, I mean, we can use 3%?
No, I would say at least 5%.
So if someone only loses 3% but still has an improvement in their AHI, we would deny them continued use.
Well,
That's my concern about putting in the weight loss piece. I think Courtney, I think it was you that just mentioned it, because the approval for this is the improvement, or is based on the improvement in sleep apnea, which I recognize largely comes from the weight loss. But that's the reason that we're using the drug, is not specifically for the weight loss indication, but it's for the apnea indication. And if that improves, I think that's accomplishing our goal, is it not?
Well, I guess the question though is it improving because so what if, let's say somebody's using, and I'm just throwing this out here, but let's say somebody's using a sleep apnea device, right?
right.
And they're using it consistently. I
Right.
would think that their sleep apnea is going to improve.
Absolutely.
And
That's right.
they
That's right.
potentially lost 0 weight. And so maybe the Zepbound is doing nothing really for their sleep apnea and their weight loss, but it's the
Correct.
device that they're using.
That is absolutely correct.
So that's the only thing that I would be concerned about, is that and for those not using a device, obviously, but if somebody was using a device, they should theoretically see improvement.
Correct. So the question is, if we're not losing any, if you're using the device, and I'll be honest with you, the devices are very good if people use them. And you can get less than 1% AHI every night without Zepbound. But the Zepbound only is beneficial with weight loss.
So what I would, at this point, let's I'll put a little structure into the conversation. So if this wording meets with your approval, why don't can we accept this as a motion from UTR?
Yes, I will.
Okay.
I will move to approve with this statement.
Okay. All right. So can I have a second, please?
Second.
All right. Then so I would invite motions to amend the wording. So I think Courtney had mentioned, like, what if the member only had a 3% weight loss? Would 3% be acceptable to members of the committee?
No.
So Dr. Marshall would not be in favor of that amendment. Does any other members of the committee would like to?
Well, but the problem is that they're using a device, they're gonna get improvement.
Okay, right. So, all right. So I guess what I'm asking now is that we have the wording as a motion in front of the committee. Would any members of the committee like to amend the language?
It's been motioned in second.
It is, but we can amend it.
Good question.
So can I make an amendment, not as a member of a committee, but
Not really. I think you can offer testimony.
Yeah, you can offer a suggestion.
You can contribute to the conversation.
unrelated to the weight loss, but can we say reduction in that demonstrates objective reduction in AHI from baseline and then you could say based on data, and then say example PSG, home study, etc., so that we're keeping it that more open as previously discussed.
Okay.
And can I
mean,
add additional testimony?
Oh, yeah, you're welcome to, yes.
Do we need to update our initial authorization as well to include more than just PSG, or are we going to stick with the PSG for our initial authorization?
Okay, so that is a great point. Keep it on the tip of your tongue and we'll come back to it.
Okay, well, let me think. I'm just thinking one other thing here. I maybe think you ought to take the sleep study device out because you'll be able to show with a sleep study device a reduction in their sleep apnea in most cases. And if you don't, then they're going on to like probably BiPAP. So if you if you're going to do another sleep study or a home study, that's without a device. So you should see an improvement with that. I would remove the sleep study device because the sleep study device is not going to be helpful here. I think you've got to show an improvement with a repeat sleep study and a weight loss.
Okay, all right.
Yeah.
So certainly, since this is your motion, you're welcome to friendly amend your own motion.
Take the sleep study device out. The sleep study device has got to come out.
Okay, so let me reflect back. Earlier you had mentioned concern about individuals who live in a highly rural area.
Right.
You would feel in that type of situation, a home study they would have ready access to a home study.
Yes, the access to the home study is going to be just as good as a sleep lab.
Right. Yeah, I'm not disputing it, but.
Yep.
Okay.
They're using them. They're using them. I've not had any problems getting them. Most people in other towns, Muncie, Lafayette, they're using them.
Okay. So you would not accept Amanda's suggestion to use the wording like, for example, a PSG as a friendly amendment to your motion?
No, I'm willing to put in a home sleep study as in the first one for the PSG. I don't think we want to keep doing PSGs.
Okay.
I would say a PSG or a home sleep study.
All right. So
the authorization.
Okay, so just to be clear, those are the only two studies that you would accept as valid for reauthorization.
Correct. You can't do a device. If they got a device and it's showing it works, you don't need the Zepbound.
Okay,
so give me 1 second. So this will be your revised motion.
Oh, yeah. Well, I typed one too.
Right, but I would also put it in, I'd also put it in the initial authorization because that says a polysonography too. I didn't see that. Or I would add that, or a home sleep study.
Okay.
In the auth.
Yes. We will take that on as the next motion to address.
All right. I'm good with this.
Right now we're discussing the reauthorization criteria. So I forget who seconded your motion. Brian?
I did. I'll second it again.
Okay, Dr. Patel. Okay, all right. Thank
right.
you, Dr. Patel. All right, so this is the current motion. Sorry, Amanda.
You're fine. We were both typing at the same time, and we said basically the exact same thing. So.
Yeah. We can work.
All right.
Okay, so I am hearing no further discussion regarding the motion. No amendments, no other queries, thoughts.
But Dr. Shaw, you're still going to do the PSG question, right?
You mean as part of the original criteria?
Yeah.
Yes, we would address that next. We were just revising the reauthorization section.
All right.
Okay. So hearing no further discussion, Amanda?
Dr. Shaw?
Aye.
Dr. Marshall?
Aye.
Mr. Musial?
Aye.
Dr. Negendank?
Aye.
Dr. Patel,
Aye.
and Dr. Weber.
Aye.
We have all ayes, so that updated amendment will carry for the reauth.
Yes, with the appropriate typographical error corrections. Okay, all right. So I do understand that there is a desire to edit the criteria to access, and honestly, okay, we'll do the since we're talking about Zepbound here, we're revising the
Initial auth.
Yeah.
initial authorization. So this would be the
Second bullet under diagnosis, I would just add or home sleep study.
all right.
That's it.
All right. Is there a second?
Second.
Okay. Any further discussion? Okay. I'm hearing none. Amanda?
Dr. Shaw,
Aye.
Dr. Marshall,
Aye.
Mr. Musial,
Aye.
Dr. Negandink,
Aye.
Dr. Patel,
Aye.
and Dr. Weber.
Aye.
We have all ayes, so that motion will carry. And so just to make sure I've got it captured, it's going to say member has an apnea hypopnea index AHI of greater than or equal to 15 events per hour as measured on PSG or home sleep study.
Correct.
Okay, thank you.
So the third motion I would invite from you, Dr. Marshall, is to apply these changes with necessary edits to Wegovy.
No, Wegovy, I don't think has a does
It's
it
a-
have sleep
Does
apnea?
it?
It's CV.
Oh, it's just, oh, sorry, okay. I thought I had read in one of the edits. Okay, so really right now, the only one that has the sleep apnea approval is the Zepbound.
Correct.
Okay.
Today,
Alright,
could
okay.
change tomorrow, but it's today.
Probably will,
Yeah.
yeah.
All right, so what I would ask at this point is that we have revised the criteria for Zepbound. Can I have a motion to approve this category with the amended
Yes. I
criteria?
move to approve with the amended statements to the setback. GLP-1.
Second.
All right, thank you, Dr.
Second.
Patel. All right, so the motion is to approve this class with the edited criteria. It's been moved and seconded. Any further discussion? Okay. Amanda?
Dr. Shaw,
Aye.
Dr. Marshall,
Aye.
Mr. Musial,
Aye.
Dr. Negandink,
Aye.
Dr. Patel,
Aye.
and Dr. Weber.
Aye.
We have all ayes, so that motion will carry.
Thank you, Dr. Shaw. Thank you.
Thank you, everyone. It's been a very good discussion.
Yeah.
Okay. We will move on to the third item that was extracted, which would be C9, miscellaneous oral anti-diabetic agents. As a person that extracted, the reason why I extracted was the recommendations to remove the step edit sort of brought to mind the fact that the sulfonylureas as a class are not at this point considered by the ADA to be first line or even second line treatments. I mean, I'm not going to make a particular recommendation now, but what I am sort of thinking and moving on is that we should probably think about pushing people off of this class. I mean, they are associated with hypoglycemia, and we have much better agents available now and on the formulary. Excuse me, on the preferred drug list. I'm sitting in front of John, and I had to keep my language correct.
I appreciate that. Thank you.
Yeah, so, I'm perfectly okay with accepting the recommendations, but I do think that we may need to think about trying to push people out of these classes. Because there are better agents available now.
So Dr. Shaw, just something to note for you that the committee may not be aware of is we did do a retro-dur with the board around utilizing, we'll just say, more appropriate agents. It was more focused on individuals that had concomitant disease with CKD or CVD and making sure that they were using either an SGLT inhibitor or a GLP versus some of the older agents based on the guideline update and pushing towards that. So I just wanted to give you a heads up that we were looking at that on the DUR board side and really trying to move people to more appropriate agents than some of the, let's say, older therapies that maybe have kind of fallen by the wayside.
Yeah, I mean, I have to admit, 40% of my panel are patients with diabetes, and I have no one on these classes. Yeah. Okay. All right. So that was my only commentary on it. I appreciate the information you're providing, Amanda. So I think maybe collectively we're sort of thinking in a similar direction. So I would invite a motion. Go ahead.
I was just going to say, I agree. I don't have a single patient on a sulfonylurea in my practice either. But I think you get in slippery slope of these medications are still FDA approved and they're out there. And if we start dictating kind of how we want other practitioners to practice based, by restricting the PDL or whatever, like I think it's a slippery slope because you can go class by class and start saying, well, we shouldn't have that med, we shouldn't have that med, et cetera. And I think it's something that, there may be other ways like Amanda had just mentioned of directing that practice habit, but I don't know if this is the correct way of doing that if we were to remove all those meds from the PDL. So my motion is to accept all of Optum's recommendations as they presented.
Yeah. Hey, is there a second since you made the motion?
So I'll second it and add a commentary that just sort of naturally what you're referring to, Dr. Shaw, is happening in the anti-diabetic space in terms of script counts for sulfonylureas. So it's happening sort of built into the system, right? Docs are leaving sulfonylureas because of the hypoglycemia hand over fist. So it's going to happen, but there may be a patient out there that's somewhere that, maybe they're allergic to GLP-1s or other types of therapy, and the sulfonylureas are their choice. So
yeah, you can't use metformin, and yeah, you need a little low dose. I agree. Yeah.
All right. So again, I'm not offering any suggestion we make a change. It's just sort of my thoughts in this matter. So the motion's been made and seconded to approve the recommendations from Optum regarding miscellaneous oral anti-diabetic agents. Amanda?
Dr. Shaw?
Aye.
Dr. Marshall?
Aye.
Mr. Musial?
aye.
Dr. Neckendank?
Aye.
Dr. Patel?
Aye.
And Dr. Weber?
Aye.
We have all ayes, so that motion will carry. Thank you.
So at this point, we've completed the review of the classes.
That takes us back again to public comment. And again, we will restrict public comment to those that were signed up for the first session. If you wish to provide public comment in this session, if you could maybe raise your hand or come off mute and let us know. All right, I am not seeing anything, or you could shoot a message in the chat box. Don't see a hand raised. I don't see anybody coming off mute. So I think we are good there. So that just takes us to other business then. Any other business from the committee? All right, I believe that leaves us to the last item on the agenda, Dr. Shaw, for adjournment.
All right. I will go ahead and call close of the May 2nd, 2025 meeting of the Therapeutics Committee to a close. So thank you everyone for attending.
Thanks, everybody. Appreciate the discussion. Have
Thank
a great
you.
evening.
Thank you.
Bye, everyone. Thanks.
Thank you.